Hi, welcome to this short talk from the ACE Your Clinical Placement series on making a good formulation or statement summary. This is one of the key tasks for working as a student and for practicing as a doctor on a ward. My name is Matthew Links and I'm the Discipline Lead for Medicine at Bond University, and I'm speaking to you from Combermere country on the Gold Coast. Healthcare communications orientated towards action. Now, there are three critical tools to promote this that are a summary statement or a formulation, a problem list, and an action list. In this video, we're going to focus on the summary statement. Making a good summary statement is a key skill because everyone is time poor. A summary statement is a key part of the structure for a handover or a discharge summary or a case presentation or even a scientific abstract. They all represent a skill in getting down to what is really important. Now, it may be that generative AI makes this process quicker and these tools are coming. However, the issue of quality will remain critical. You need to understand what makes for a good summary. A key concept that drives all of this is that of cognitive overload. Being succinct is not an aesthetic preference, it's a safety issue. When our brains get overloaded, we make mistakes. There's an awful lot of data for us to get our heads around, and your key role as a junior doctor is to reduce the complexity and present things in a way that enable good decisions to be made. Reducing cognitive overload is everyone's business. If you're giving handover or writing a discharge summary, you don't want to write the unnecessary detail, and I can guarantee the listener doesn't want to read it. Let's just get good at reducing the unnecessary information in the system. One helpful question to ask yourself as you summarise the case presentation is to say, what sort of problem is this? Is it a diagnostic dilemma? Or do we know the diagnosis and the problem is of routine management, let's say a routine management of a non-STEMI? Or perhaps the problem is routine management in a context, in a patient on dialysis. Perhaps the problem's a management dilemma. Do I thrombolyse or don't I? Now, you don't always have to put this in and explicitly say that this is a diagnostic dilemma, but it's always helpful to understand what it is you're dealing with. The skill that helps me the most is the ability to synthesize. Medicine is full of useful shorthand formulations that are incredibly rich ways of communicating. If you tell me a patient has locally advanced triple-negative breast cancer day 8 of AC, I'll know an awful lot of important information about their prognosis, likely toxicities, the time course for improvement. If you tell me someone has severe symptoms despite standard management, then I know I need to think about escalating the interventions. One trap is around acronyms, which can be great as long as the person listening knows them too. There's some evidence that most GPs don't know the really specialised acronyms that a specialist team use. Being concise is a skill. Practice it. Look at what you've written or said and think, could I have made it any shorter? Practice editing. Now, the most important guide to a good formulation is to ask yourself, what is the decision to be made now? Is it, do I thrombolyse this patient with a stroke? And if that's the question, the fact they don't have any contraindications would be really useful to include in the summary. If it's, do I need to admit them? Well, then the information they're homeless would be worth including. If the question is whether to leave the MRI until tomorrow, then the time course of their deteriorating symptoms, let's say slow onset back pain over a week, might be the priority information. What the decision is determines a lot what the important information is. But deciding what's important is more than just about decisions. It's also asking, what do I need to know to look after this person safely? Try to think outside the technical lens. If something in the social history is critical, put it in. Having caring responsibilities influences whether a person can come in for admission or what you need to do if they do. Knowing someone's non-English speaking influences whether you can see them without an interpreter. Shorthand ways of assessing risk or severity are important. High-risk febrile neutropenia on MASC criteria, for example, or the phrase hemodynamically unstable. There may also be red flags for any particular presentation, such as suicide risk or the risk of non-accidental injury in a child, or the criteria for risk in diagnosis of pulmonary embolism by Wells criteria. Stating someone has cirrhosis is good. Saying they have child C cirrhosis is better. Some issues are important because they're potential safety issues. Living alone is a safety issue for discharge, or saying someone's a high falls risk. And some issues are quality issues because we know they easily get missed. For example, follow-up of an incidental finding on a discharge summary is something that can easily go wrong. The hard thing when you're not sure about what's important is what to leave out. I'm not talking here about leaving out information altogether. I'm talking about leaving it out of our summary statement. So if there's no need to include all the details of a patient's symptom, if it's a management problem and the diagnosis is made, these details can be given later. And you don't need to include all the inactive problems in a summary, only if it impacts on care. So if a patient with a urinary tract infection, their hypertension may not be important, but their poorly controlled diabetes will be. This is because their sugars may well be unstable while they have an infection, and the management plan is going to need to deal with this. A common mistake of students and juniors is not to make a commitment. A diagnosis is the best piece of synthesis you can have. It communicates a lot, so make a commitment. Many patients come out of hospital with a presenting problem the same as the discharge diagnosis. They came in with chest pain and they go out with chest pain. If it's not certain, it's still better to say it's likely coronary artery disease or suspected coronary artery disease than leave it as chest pain. If the issue is a diagnostic or management plan, then also you can make a commitment. Now, to link summary to action, one technique is to telegraph intent. Communicate what you think the issue is and what help is required. If the main issue on discharge is emotional support after their cancer diagnosis prior to their oncology appointment, saying so helps. So here are some examples of brief summary statements that include a wealth of information with a few words and help the listener with ongoing care. I'll let you look at them. So making a good formulation is a key skill. It promotes safe care. Identifying what sort of problem it is helps. Remember, what you leave out is just as important as what you put in. Synthesize, synthesize, synthesize. Make a commitment and telegraph intent. So I hope you found something useful in this talk and have found at least one thing to try to use to improve your patient formulations. If you're a Bond student, look up resources on the Learning and Practice page on iLearn, and I'd invite everyone to look up our other videos in this series and others on Vimeo or YouTube. Please leave us a comment or a request. I've also posted some other resources you might find useful. Good luck, and may your summaries be succinct.